Hello, welcome to Fertile Minds. I'm a fertility specialist, Dr. Andrew Cary, at the Queensland Fertility Group, based here on the Gold Coast. Today, we're going to talk about endometriosis. We're particularly going to cover the symptoms of endometriosis, but then also touch on some of the diagnosis and the excision treatment, and then following with how we might help somebody for fertility treatment. Endometriosis is a very common condition for women, and women of all ages, but particularly women of the reproductive years. Endometriosis can occur in teenagers, but also women in their 20s, 30s and 40s, and they're particularly the patients who are attending for us to help them with subfertility. The symptoms of endometriosis are quite many and broad and varied, but the most common symptom is one of pain, and typically of a chronic pelvic pain. This chronic pelvic pain can be quite disabling, it can be dull, it can though be quite burning and even sharp. So it's quite variable, but it is often and very, very frequently associated with pain at or around the menstrual period. The medical term we have for this is dysmenorrhea. Women who experience dysmenorrhea will often have the unfortunate scenario where they do need to take some time off of their daily activities or their work activities or their sport activities around the time of their menstrual period because of the severity and the disabling nature of their pain. On top of that, there is a frequent symptom of pain with or after intercourse, what is referred to medically as dyspareunia. Pain with or after intercourse is a very frequent indicator of endometriosis. There can be other symptoms. There can be symptoms related to the bladder. There can be symptoms related to the bowel, and it often helps us to pinpoint where we might find lesions of endometriosis at treatment and surgery. However, there is a big crossover between some of these symptoms and somebody who doesn't have endometriosis. And so it's very common that if we find some of these symptoms, that we're needing to confirm it in a more accurate diagnosis. Sometimes our transvaginal ultrasound can help us to see large ovarian cysts that we call endometriomas, or chocolate cysts is a common lay term. But other times the ultrasound is completely normal, and other investigations such as CT scans or MRI scans would be completely normal as well. So the diagnosis does very frequently rely on laparoscopy, what we refer to medically as a diagnostic laparoscopy. Typically, however, once we do find endometriosis at laparoscopy, we will then go on to perform further excision or ablation or removal of these endometriosis lesions or nodules or patches or plaques. As well, we can perform at laparoscopy an ovary cyst operation to remove any endometriomas or chocolate cysts at the time. The principle of doing our laparoscopy is, number one, make the diagnosis. Number two, do the corrective treatment to maximise the chance of removing of endometriosis, and that's to provide symptomatic relief, and so that's a very important part of our treatment of endometriosis. The surgery can be quite extensive and it requires an anaesthetic, and it requires often a short post-operative recovery time, briefly in the day surgery or the hospital, but then some recovery afterwards. Frequently these patients then have recovered very quickly, but we quite commonly, almost universally for the subfertile patient, are moving on to fertility treatment to follow. The fertility treatment often, but doesn't always, involve IVF. Thanks for watching, and please be sure to subscribe so that you can cover all topics about fertility.